Okay. Good evening. Today is April 22nd, 2020, and it is 5:30 p.m. As a quorum of the board is in attendance via our video conference link, I would like to call to order this meeting of the Central Health Board of Managers. For the members of the public joining us this evening, I want to note that technical and security issues prevent us from offering video conferencing. Members of the public may only participate through audio for the time being. We are working with our teleconferencing vendor and hope to have these issues corrected for future meetings, which would then allow the public to participate via video. The recorded audio and video stream from this meeting will be posted on the Central Health website as soon as possible after the meeting. The first item of business is the public hearing on the payment rate for the district's local provider participation program. Before we accept comments, we will receive a short presentation on the proposed change from Katy Coburn.
Good evening. Thank you, Chair Greenberg. I'm Katy Coburn on the finance team at Central Health, and I'll be presenting some information about the proposed amendment to the LPPF FY20 payment rate when I find my presentation to share. In any case, I will go ahead right now and we can and just let you know that in January of this year, the Board of Managers set the original FY20 mandatory payment rate at 2.38% of net patient revenue. That rate was intended to generate about $76 million to support IGT for Medicaid supplemental payments. The proposed amendment before you tonight increases the payment rate to 4.17% of net patient revenue, which will generate an additional $57 million for a total annual amount of payments of $133 million. The additional payments are intended to provide the local portion for payments to hospitals as part of the Uniform Hospital Rate Increase Program, or URIP. URIP payments were not accounted for in the original setting of the FY20 rate. HHSC was intending to change its administrative methodology, which would have delayed IGT for URIP until FY21. HHSC decided not to make that change, and thus is going to be calling for URIP IGT in June and in August of 2020, creating a need for additional LPPF funds to support those payments. And with that, I'll turn it back to you for public comment.
Madam Chair, you're on mute.
Thank you. Very helpful. Thank you, Katy, for those comments. We appreciate your assistance. We will now receive public comments on amending the mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2020 in connection with the local healthcare provider participation program in Travis County. Yvonne Davila of the Central Health Communication Department will briefly cover the guidelines for the public hearing portion of the meeting and will then introduce all commenters by name and invite them to speak in turn. Yvonne?
Thank you, Madam Chair. In order to be recognized to speak, you must request a speaking slot using our bilingual online form or by leaving a voicemail by 4 p.m. the day of the meeting. Individuals are asked their preferred language as they register to speak, and both the online form and voicemail greeting are in English and in Spanish. All speakers will be recognized by the name and in the order their speaking request was received. Please keep your phone muted until you are called on to speak. Please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number, in this case, the public hearing. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Once again, speakers will be muted at 3.5 minutes to ensure the efficiency of the meeting. Speakers may not donate their time to other speakers. As a courtesy to others and to be respectful of time constraints, please try not to repeat other speakers' comments. Depending on the number of speakers and the total time being spent in the public hearing, the board chair may, in her discretion, impose additional limits on time or comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issue for discussion at a future meeting. And with this, I will call the first speaker. His name is Jeronimo Rodriguez with Ascension Seton. Jeronimo, you can unmute your line. Mr. Rodriguez, can you unmute your line?
Good evening. Can you hear me?
Yes.
Yes, thank you.
Great. So thank you, Board of Managers. I am here this evening in my role as Chief Advocacy Officer for Ascension, Texas, which includes Ascension Seton Del Children's Medical Center and all of our facilities here in Central Texas. On behalf of our President and CEO, Andy Davis, and our 12,000 associates, thank you all for your support of our frontline staff as they work hard every day to take care of our community during the COVID pandemic. Ascension, as you know, has been in Central Texas for over 118 years, and we are so grateful for the community showing support for our doctors, nurses, food service workers, environmental service workers during this pandemic. And our mission calls us to advocate for a compassionate and just society with our actions and our words. And this includes over $250 million a year in charity care to our community, as reported to the state of Texas. We are here tonight to ask for your support of the Central Health staff recommendation to maximize the support for all of our healthcare organizations as we take care of those most in need. We take our critical role in Travis County, in the Travis County safety net healthcare system very seriously, including the care we provide in our 4 teaching hospitals. We appreciate the public-private partnership with Central Health, which furthers the care we provide in our community with special attention to the poor and the vulnerable. And as part of the commitment to the Travis County safety net, Ascension, Texas is working hard to ensure our hospitals have access to adequate resources, both to combat COVID-19 and provide healthcare to vulnerable Texans. One key aspect is to ensure existing Texas Medicaid supplemental payment programs, such as the Uniform Hospital Rate Increase Program, are fully funded in this challenging time. Fully funding Europe requires Central Health to do 2 things: support utilizing that an assessment rate to return the greatest amount of resources to our community as authorized by the Texas Health and Human Services Commission for all categories of eligible hospitals, and amending the Local Provider Participation Fund mandatory payment rate so there are sufficient resources available to fund the rate increase. And the LPPF assessment rate will allow our federal tax dollars to come back to our community to provide care to our most vulnerable individuals experiencing poverty. This means our local property taxes do not need to be raised to draw down these critical dollars. And again, I just want to say thank you for your partnership throughout the years and especially during these times. Thank you.
Thank you very much.
Madam Chair, the next speaker is Ms. Renee Nicole Rain with St. David's Medical Center. Ms. Rain, you can unmute your phone now or computer.
All right, can everyone hear me?
Yes, I can hear you. Thank you.
Oh, thank you. My name is Renee Rain, and I'm speaking on behalf of St. David's Medical Center regarding the proposed LPPS increase. St. David's does not support increasing the assessment rate up to 4.17% and believes that a lesser rate would be more appropriate. A portion of the LPPS rate being proposed will support Europe payments to some Travis hospitals, and this proposed rate will impose a greater tax burden on hospitals like St. David's and Del Seton that are paid 60 to 68% of cost, or $31 million under their cost, without providing them an incremental year of benefit from that increased tax burden. The benefit of the higher proposed LPPF rate will flow almost exclusively to Dell Children's, which is already paid 102% of its total Medicaid costs. The higher LPPF rate paid by St. David's and Dell Seton would then support a payment increase to Dell Children's by an additional $25 million above the 102% cost baseline. St. David's disagrees with imposing a higher LPPF rate on these underpaid hospitals in order to increase payments to a single hospital by $25 million. It's not good public policy to increase the tax burden for hospitals like Dell Seton and St. David's solely for the benefit of Dell Children's. Instead, St. David's believes the rate should be closer to 3.8%, which would fund only the Europe rate increase that will be directed at benefiting all of the LPPF hospitals that treat Medicaid patients. Thank you.
Thank you very much.
Madam Chair, this concludes, this is the end of the public hearing. There's no one else signed up to speak.
Thank you very much. At this time, we will now proceed to the regular agenda. We will be taking the agenda out of order this evening. Item 4 will be considered after item 6. That will allow us to enter closed session only once, if necessary, for the 2 items which may need a closed session. So the final agenda order this evening will be as follows: 1, 2, 3, then 5, and then 6, followed lastly by 4, and then 7, which is adjournment. So proceeding to the regular agenda, number 1, discuss and take appropriate action on the proposed amended mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2020 in connection with the local healthcare provider participation program in Travis County. Katy Coburn will be presenting. Katy.
Good evening again. I am this time going to successfully share my screen with you right on time. And as that loads, I will begin. So as we discussed during the public hearing, Central Health staff are recommending that the Central Health Board of Managers approve an amendment to the FY 2020 LPPF mandatory payment rate to increase it from 2.38% to 4.17%. As a point of context, the maximum LPPF payment rate allowed by law is 6% of net patient revenue, so we are under that. The chief reason for this mid-year amendment is to provide sufficient IGT capacity in the LPPF program to support the Europe program, which was not included in the original rate setting process, as I mentioned before. The new rate will collect a total of $133 million in mandatory payments, which is an increase of about $57 million in revenue over the original rate. The proposed rate is intended to cover IGT for several programs in addition to Europe. The uncompensated care program estimated IGT need at about $68.5 million. Additional uncompensated care program payments related to the Children's Hospital of Texas lawsuit, about $2.7 million in payments. And as I mentioned, adding additional revenue to fund IGT for the Europe program, estimated needed about $53.2 million with an additional cushion in case there are changes to those estimates as we go forward. Let me advance the slide. So that's what I just discussed. And the proposal we received was for a payment rate of 4.17% of net patient revenue. Central Health staff have evaluated this and find that it is sufficient to fully fund IGT needs for Travis County hospitals and maximize federal funding in all available supplemental payment programs. as we understand their availability today. As part of our public information process, hospital representatives were emailed notification of the public hearing for the rate amendment last week, and also published notice of the hearing in last Friday's Austin American-Statesman. And as I stated, we recommend the board approve the proposed amendment to maximize those federal funds in all programs. And with that, I'm happy to answer any questions.
Members, do we have any questions? Let's see, I see Manager Valadez and then Manager Oliver. Manager Valadez, you need to unmute.
Sorry. Mine's very simple. We fund the Seton, which is Ascension, and the St. David systems, or HCA systems, hospital systems, that they're on either side of this motion today, this change in rate. Is there a reason why? What would be the bottom line reason?
I can explain what I understand about that, if that's okay.
And Mr. Knodel might want to add to that if he is here. That would be fine too.
Thank you. So in the Europe program, there have been a number of changes that HHSC has made over the past year. One is the decision not to delay IGT until FY20, which is requiring this discussion right now. The other thing that they have done is they have significantly increased the overall statewide funding pool for Europe. And specifically in the Travis SDA, Service Delivery Area, which is the 8-county area in which Travis is part, the overall pool increased from about $67 million up to $143 million. So there are additional funds available in Europe. And finally, for program year 4, which is what is being funded through in FY20, HHSC has revised its allocation methodologies across changes in classes of hospitals. And the allocation revision is related to the Children's Hospital of Texas lawsuit and how their funds are calculated for programs like this. And the change for program year 4 does tend to direct funding, at least in our SDA, more towards children's hospitals compared to what they received in program year 3, because the funding pool is larger overall. All classes of hospitals are receiving additional funds, although the percentage increase for children's hospitals is greater.
Is that a good analysis, David? I mean, Jeff?
Yes, that is a good analysis. There's been a significant increase of funding. I think the issue at hand is that from a reimbursement standpoint is are the Children's Hospital, or is the Children's Hospital receiving additional funding above their Medicaid shortfall? So again, the methodology was determined by HHSC given the methodology they have to follow through their administration of the program. So there's nothing we can do about how the funds are allocated across the hospitals. Simply put, we're trying to maximize funding in the region, in the SDA, as it relates to our IGT capacity to participate in this program.
Okay. So, so you're in support of the increase in order to be able to accommodate the growing needs from the hospitals within the district, correct?
Yes, I think the motive of Central Health has been to try to maximize funding. And, again, we don't control the allocation across the hospitals. HHSC, that's something they dictate to us.
Okay. Are you willing to entertain a motion?
I think Manager Oliver, did you still have a question? Yes, Manager Oliver.
So I guess my concern is listening to both Ascension and St. David's in the public comments. St. David's concern is that if you go above a 3.8%, that's primarily going to benefit Dell Children's, which gets 102% of its Medicaid anyway reimbursed because it has a very healthy insured population. And I guess I have concern of implementing a tax on hospitals at this time above a certain threshold that they don't all agree to. If there's an amount that they agree to, I would say we should limit or cap it at that, because this is a very trying time for all the hospitals. I mean, Ascension, Seton, or St. David's, Baylor, Scott and White. I mean, this has been a really hard time for all of the hospitals, and I would ask the board to consider capping it at 3.8%, so that you're not harming hospitals in this time in which they're already hurting.
I see some other hands. I think Manager Bell, and then I'll look for more hands.
My question, Jeff, would be, if you capped it as Manager Oliver outlines, does that change the allocation? So wouldn't the children's hospitals continue to get more just because it's the allocation by HHSC, or am I wrong?
I think what they're proposing, and my apologies, this is the first we've heard of this rate at the public hearing, but as I understand, the rate is calculated to bring Dell Children's up to their Medicaid shortfall to not exceed the shortfall for that one hospital. So again, the Children's Hospital is, under the proposed rate. And again, we haven't had a chance to run the numbers. This is the first we're hearing of it. But if I understand the speaker correctly, it would reimburse Dell Children's above their cost, and the 3.8 would take that particular hospital to 100%. But if you look at the hospital networks as a whole, there's still a decrease to the system as a whole, into the hospital networks as a whole, by decreasing the amount of funding.
That's right, because if I could just add that,
Please do.
because we are required, because HHSC will follow its allocation methodology as it has decided. So to your point, Dr. Bell, regardless of the rate we set, HHSC's methodology will be in force.
A quick
Manager
follow-up.
Musaitov, well, let me, I think Manager Musaitov, you had a question?
Well, thank you for the presentation. Given the public comment, I agree with Manager Oliver. At this moment in time, I don't really feel comfortable with the rate, given that we have not really studied it. So I propose either that we not vote tonight until we have the numbers, or whatever. I just don't feel comfortable at this moment in time. Thank you.
So I do have a question. What is the deadline by which this board must take action?
The next Europe IGT call will come in early June. So
Okay.
So that was when if we want to participate in that program or participate at some level, we will need to be able to make a decision before then. And hospitals will need time to remit their payments as well.
So in your expertise, or in Mr. Knodl's, what is the date by which this board must take actions for everything to be implemented for June?
So if we are having a special called meeting next week, which I'm surmising we are,
Yes.
we could come back next week, evaluate the additional proposal, and I would agree at some point, the hope would be that all hospitals are in agreement to the rate, and we would simply come back. I think that gives us sufficient time
Okay.
to invoice the hospitals at the correct rate and to remit payment to participate in the program.
So if I heard correctly from Katie and from Jeff, we never heard about this new rate that has been proposed by St. David's until the public hearing that we just had, which, by the way, if I did not say, that public hearing was closed, and to my knowledge, we did not have anyone for regular public comment. Was that right, Yvonne? We didn't have anyone signed up?
That's correct. We didn't have anybody signed up for public.
Just want to make sure everybody understood that. So, but to my, Katie and Jeff, this new rate that we just heard about from St. David's, we never heard anything about it until 5:30 this evening when they commented in the public hearing. Is that correct?
Yes, that's correct.
And so you said you, Mr. Knodel, have not had time to analyze those numbers, obviously, since we just received them shortly a few minutes ago, right?
No, well, we would like to look at them, but again, we would like to work with the hospitals. I mean, again, I think the goal in this is to have total agreement
Right.
with the hospitals. So coming back next week would give us some time to work through that.
Members, that seems like a reasonable course of action to me.
Yes.
Okay.
Madam Chair.
Okay. All right. Well,
I know that Manager Oliver had a follow-up, but after
I'm sorry. Manager Oliver, did you have a follow-up?
I'd like to make a clarification.
Manager Oliver?
I'm good.
You're good. Okay. Sorry. I'm trying to follow all the hands.
Maram addressed it in her comments, actually.
Okay, great.
Thank you, Maram.
Thank
So,
you.
Madam Chair,
Yes, sir.
we did receive a written correspondence shortly after 4 p.m. today from HCA St. David's, and that was circulated to the board members via email
Okay.
regarding their position.
Thank you for that update. So shortly before this board meeting tonight, we received something. Of course, not everyone has the ability to keep up with email by the moment, but I understand something was sent out via email at around 4 p.m. today, you're saying, prior to this 5:30 meeting?
We received it shortly after 4 p.m. and it was
okay.
circulated to the board at some point before this meeting. I'm not sure the exact time.
Okay, so there wasn't a lot of time, is my point, in between you receiving that, your ability to get to the board, and the board having a meeting commencing at 5:30 p.m., correct? Okay.
I don't see it in my email. I mean, I could,
Okay,
I don't have a lot that's in my inbox, so I just don't see it. If they could send it, that would be great.
Right.
I got it. They might need to resend it.
Okay, so we'll look into that. That's
So it's on the top of the box. You can see it. Okay, thank you.
okay. Can we move on? Okay, so we'll move to agenda item number 2. Receive and discuss a briefing on the Central Health Enterprises responses to the current COVID-19 pandemic, including response activities pursuant to local, state, and federal guidelines and orders, current and potential fiscal issues affecting the Central Health Enterprise, available sources of reimbursement, and clinical and testing site operational status and challenges. Mike Giesland will be presenting along with the following: Jeff Knodel, Jason Fournier, Kit Abney, Spels, Ted Burton, and Sarita Clark-Leach. And managers, I would ask that you please hold all of your contents until all the presenters have spoken. That's much easier to manage with the technology. So please wait until everyone has presented on this item, and then we'll take up questions. Mr. Giesland.
So members, thank you for your time and attention this evening. Tonight's update will cover the same subtopics as last week, with one new topic introduced and related to the various fiscal issues and fiscal impact affecting community care and Central Health as an enterprise. First, I'll start with the operations overview. Central Health continues to operate under a business continuity plan and with all functions operating remotely in a disrupted environment. We are currently at a level 3. Again, that refers to full remote functionality, and we've extended this to 22 May to give us some time as the various orders are changed either at the state or the local level to make sure that we transition back into the workplace safely and appropriately. I have been asked if we will cease all remote working whenever the various orders are relaxed or over some period of time. And the answer is it remains to be seen, but I think there will be some continued utilization of remote working, perhaps in a staged fashion over time. Again, I want to work with the staff teams on this before making any final decisions. But I think it's important that we remain functional as a hospital or healthcare district, but also able to pivot quickly should a resurgence occur and we have to send everything back out remotely. One of the silver linings in our current operating environment under business continuity plan is that I feel like we've become much more efficient and we're better utilizing some of our technology tools. However, I do recognize that we will need to enable some in-person team connections across all departments whenever the situation does allow. On the community response, I want to remind everyone that we are still under state and local declarations, so that is emergency and or disaster declarations, and that this is a public health emergency, and we're working in conjunction with the locally managed emergency operations center. In that vein, Central Health continues active monitoring or direct participation in 4 task forces, and those include alternative care sites, mass casualties, social services, and contact tracing. On the contact tracing, you will hear about this more and more as we're able to test more and more. We're advised that Austin Public Health is well resourced to conduct contact tracing. However, we've entered into a data sharing agreement with Austin Public Health and Community Care to make sure that we're able to respond quickly if called upon. An issue that comes up in the course of our local emergency operations meetings is the clusters in nursing homes, and you've read it and heard about this as well, but I wanted to elaborate some. Currently, there are nursing homes and assisted living facilities that are areas of concern because of the concentration of COVID infections. There are new control orders that have come from the city of Austin that restrict new and returning individuals coming into these facilities. And I believe that includes both residents as coming from the hospital as well as staff persons. And we're performing an internal analysis with respect to Central Health and to what extent these control orders may have on our medical access program patients that utilize skilled nursing facilities and how we can mitigate any disruption in service of those individuals that are receiving skilled nursing services in the medical access program. That's the community response. But before I turn it over to the others, I'll ask Megan Cermak if there's anything that you feel like needs to be highlighted in light of the calls that we've had today.
Mike, I have nothing to add.
Okay. One piece of commentary on the community response, thank you, Megan, is, what's the exercise here with respect to lifting the various orders and bringing the economy back online and increasing the level of social interaction. And again, this is just my commentary and my opinion on this, but we need to be very careful about how we go about doing this. Otherwise, we'll be back in the same place 2 to 3 weeks later if we over-relax what some of those conditions are. And what we're doing is trying to buy more time so that we can do more testing. The more we test, especially in those hard-to-reach areas and disproportionately impacted areas and communities of color, the more we learn about this disease and the more we uncover and unmask any trends that are sitting out there that we just don't see right now. The second concern is enabling the stand-up of alternative care sites. I know John Morgan and others in his team and Barbara Adams are working on that alternative care site task force and providing support as well as technical expertise. And I think this is important because should we have a resurgence and we start pushing to surge capacity in hospitals, we'll need those care sites stood up or in a position where they can be deployed in a matter of a day or so to be able to take the capacity that might come from the hospitals. So those are 2 key factors, and those aren't just health resources issues. They are certainly equity issues for the communities and the individuals that we're privileged to serve, to make sure that everybody receives the care that they need. So that's what a lot of the discussion on the regional calls regarding, how do we bring back various social activities, but also business activities, and what's the effect on should we do that too soon, too early, and not in a thoughtful way. We have other presenters tonight. As the chair mentioned, Kent Abney Spells will cover the MAP and MAP Basic enrollment issues. Ted Burton will cover the communications. Sarita Clark-Leach will cover data analytics and reporting. And then followed by Jason Fournier on clinical operations and testing update. And then Jeff Knodel on the fiscal update. And I understand Jason or somebody from his team will also have additional information on fiscal issues as well. So I'll turn it over to Kit to cover the medical access and medical access basic issues.
Thank you, Kit. Kit, are you with us?
Hear me?
Now I can, thank you.
Hi, can you hear me?
Yes, I can hear you. Yes.
All right,
yes.
sorry. My headset died. Not good timing. All right, well, I was about to say we are very excited that we did a soft launch last week of our online application and our pending docs website. Those sites are applyformap.com as well as inscribirse.map.com. We do own .net, .org, and .info as well in case anybody were to go to those domains. As of Sunday night, we had received 83 submissions through the online portal, 77 through the online application, and 6 individuals had submitted documents through our pending site. We are working on communications to go out to our community partners, and we're working with our communications team to create a video that can be shared through social media, as well as any opportunity to get some paid media. Next slide, please, Brianna. So in tracking our applications, as you can see by this, the month of March, we had our highest number of individuals applying for coverage, 14,000 in the month of March. And this was about 2,700 more applications than any of the other months prior. And our highest month prior to that, sorry, not 2,700, it's 1,300 more applications than we received in October, which is our second highest month this fiscal year. We will continue to update these weekly, so the April numbers will continue to grow, and we'll provide this to you. Lastly, next slide, Brianna, is looking at our enrollment. As you can see, our MAP enrollment continues to grow. If we look back since March 1st of this year, we've seen an increase in 2,400 MAP members and an overall increase in both of our programs of just over 4,700 new members in MAP and MAP Basic. I do want to remind you that due to our enrollment extensions that we put into place, the only individuals that are dropping off of coverage currently are those that we found enrolled in Medicaid, Medicare, or they contact us and report a change that makes them ineligible for coverage. So you will notice that we saw a slight decrease in enrollment of MAP Basic on April 19th, and that was due to the fact that on the 1st and the 15th of every month, we do bounce our full enrollment file against Medicaid enrollment and go through a process of disenrolling those that now have Medicaid coverage. So we always see sort of a slight dip mid-month and then it starts to kind of pick up again. And that concludes my report.
Thank you. Next presenter, please.
Good evening. This is Ted Burton, Vice President of Communications. We gave you a pretty comprehensive update last week on communications and community engagement and outreach. This week, I want to briefly touch on what's happening from here forward, starting with virtual advisory committee meetings. As you know, Community Care is leading bi-weekly virtual community conversations regarding COVID-19. So our team is now planning and will be coordinating virtual advisory committee meetings to keep residents updated and engaged in planning for long-term sites in Eastern Travis County. We want to make sure that they know that long-term planning is continuing in spite of our COVID-19 response. So we are working with our internal Eastern Travis County project team on appropriate timelines for gathering public feedback on the development of these long-term sites in our priority areas. I apologize for the dogs in the background. While our advisory committee meetings paused due to COVID, our team has remained in close contact with members of the advisory committees, making phone calls and emails, and also joining some conversations and virtual meetings that we did not host. But we are planning virtual advisory committee meetings for Northeast Travis County, which includes Manor Colony Park, Austin's Colony, Hornsby Bend, Southeast Travis County's advisory committee, which is Dell Valley Creedmoor, and Pflugerville. So residents will be able to join by phone or video conference, and we're also planning to begin monthly email updates immediately. Stand by just one second. Apologize. Next, for virtual community conversations, as we are stabilizing our operations, given the COVID-19 response, we're also beginning to plan a series of virtual community conversations. So as in previous years, we will look at the organization's strategic priorities, our proposed 2021 budget, and then other topics as we determine are important and timely. And just as our outreach and engagement efforts include using methods to reach people with no internet access, we will do the same for our virtual community conversations. Finally, I want to talk about outreach. So grassroots outreach. We mentioned last week that we are adopting a new texting platform to complement our outreach and engagement efforts. We are addressing some legal hurdles that we have been working through, primarily that recipients must give us express consent before we text them. So we've been talking to the City of Austin and our vendor and one of our public relations consultants to make sure we do this the right way and the legal way. There is an opt-in form for texting on our COVID pages on our website, both in English and Spanish, so that we can segment audiences. And we'll be promoting a short code, which is the phone number that we use, which if you want to write this down, we will also send it to you. It's 47177. Again, that's 47177. And then we will use keywords to assign people to specific lists, whether they want English or Spanish text. And we're going to promote this through our direct mail initiative, through paid media, and then on all of our printed pieces, so flyers and banners and posters, etc. And of course on all of our social media channels and through our advisory committees. This is a brand new program for us and a brand new platform, and Mike McKinnon has been leading the way to help us navigate this. It is heavily regulated by the industry and the government, and so we are having to learn some of this as we go because it is a first for us, although Sendero currently uses texting. When it comes to phone calls, I mentioned this last week, but we are continuing to call MAP members, specifically those who don't have internet access in Eastern Travis County. We're making those calls in English and Spanish. We're talking about prevention and protection, testing sites, and updated testing sites and clinics that are reopening, and we're continuing to emphasize telemedicine. In our first round, we made about 400 phone calls, and we had a 50% connection rate. And so now we've started working through that list one more time. I mentioned direct mail last week. We have finalized the first direct mail piece. There'll be 3 rounds. One is on COVID protection and prevention. The next is on healthcare and coverage. And the final piece will be on screening and testing sites. And we believe we will get that first mailer out Friday. We're really appreciative of Community Care, our partners. They are going to actually send the mailer out. But the piece itself, the direct mail piece, it's a postcard, is co-branded Central Health and Community Care. And again, everything we're doing is in English and Spanish. And we are focusing on 11 priority zip codes that we've talked about before. Finally, our Community Health Champions program, believe it or not, it's time to recruit the next class. It seems like we just celebrated the graduation of our really amazing 2019 class. But we are accepting applications for the 2020 Community Health Champions program. And our program leaders, our amazing leaders of Davila and NIE's Cruz, are recommending that until further notice, the Health Champions program will take place virtually and over the phone. And so applications will be open from May 1st to June 14th. We will send you information about how people can apply and hope that you will share that with your network so we can cast a wide net for the most qualified candidates possible. And with that, I am finished with our communications and community engagement update.
Thank you. Next speaker, please.
Hello, everyone. Can you hear me?
Yes.
Great. So last week we presented data that showed the counts by zip code and as well as the rate of increase from the previous week of those counts. And this week we decided that we would look at a couple of different metrics to really speak to the idea of growth over time as well as per capita rate. So in just looking at overall Travis County numbers, one of the metrics that we're introducing here is doubling time. And some of you may be familiar with that metric. It's essentially looking to see how long it takes a population to double in size over time. And that gives us an indication of continuous growth, whether or not something is, stagnating, slowing down, growing. And you'll see that looking at Travis County number of confirmed COVID-19 cases from the 23rd to of March to the 20th of April, that growth has slowed considerably. So we're stabilizing at about average of doubling of about greater than 7 days, which compared to those worst affected metropolitan areas in the United States, it's significantly less as they come in at about 4 days. Next. So again, last time we looked at these, we examined those zip codes with the highest total number of confirmed cases in Travis County. And you'll see here, these are the zip codes that bubble to the top. And all of them do indicate growth over time. But we decided to also add to this, and if you'll go to the next slide, a per capita rate as well, because it's not just a matter of how many folks in the zip code are confirmed with COVID-19, but what that density within that zip code looks like. So in doing that, looking at the highest per capita rates combined with that estimated doubling time in days, these are the different zip codes that bubble to the top. And relative to, again, that per capita rate, that density, and as well as how frequently the number of confirmed cases is growing. Next. And these are some examples of high per capita case zip codes with relatively slow or no growth over time. So, and there are even some negative values in here for some corrections that Austin Public Health may have made in the numbers. When we review the numbers, we noted that on the 14th, Downtown Austin reported a number of 34, but then that was corrected to 33 on the 20th, and the same for Tarrytown, actually. Next. Looking at race and ethnicity breakdowns, it looks like, looking at ethnicity first, that there has been an increase in the number of folks who identify as Hispanic or of Latin American descent in the last week. And as a matter of fact, these numbers change very quickly. They're low numbers, so they tend to be volatile. I looked at the APH website today and saw that the number had gone from 41% of proportion of Hispanics on the 20th to 45% today. So although this, states that the growth has slowed in the last week, that growth has increased again. It certainly isn't as significant as it was between the 8th and the 13th, but we do need to continue to monitor that. As far as the other, the breakdown of proportionality relative to race, we see that the proportion of white folks who have has decreased since the last time we reported. Folks who identified as Black stayed the same. Asians stayed the same. Other increased a little, and we had an increase in the unknown population as well as of 1%. Next. So these are our 10 zip codes of interest, 10 zip codes that we should keep an eye on. And again, the number, we try to pull these numbers on Tuesday morning to get this information to you for this meeting. But again, the numbers do change quickly. As a caveat, the same caveat I made the last time this was presented, these new confirmed cases or increases in confirmed cases in these areas could be attributed to additional education about testing and additional testing too. So it's really hard to tell at this point what those cases can be attributed to, if whether or not it's the inability to adhere to those mitigation efforts, or if it is testing impact on the numbers. Next. And these are just the references. Thank you.
Thank you. Next speaker, please.
Yeah, good evening, Chairperson Greenberg and Board of Managers. Jason Fournier, CEO for Community Care. This evening, joining me in our Kramer Administrative meeting room is our Chief Operating Officer, Yvonne Camarena, and our Chief Financial Officer, Joy Sloan. I want to just take this opportunity. We're going to give a quick update in terms of where we are with our testing initiatives, as well as where we are with reopening, and then a couple quick slides as it relates to personal protective equipment. I'm going to have Yvonne speak to our testing initiatives and our reopening of clinics, but before doing so, I just want to publicly acknowledge Yvonne and her staff and the tremendous work that they've done in getting these testing sites stood up. As you can see up on the screen on the right-hand side, that was a text message earlier today to me. And that was our team standing up, literally standing up, hands on their sides, cool picture of them standing up our testing site at the Manor Senior High School today. So with that stated, I'm going to flip it over to Yvonne, and I'll zoom in on her because we got fancy equipment here that allows us to do that, which drives my staff nuts a little bit. But Yvonne, if you don't mind taking it away.
Sure, I'd be happy to. Thank you, board members, for allowing us the opportunity to just give you an update this evening about the efforts that we have to ensure that we're have as many opportunities to test for COVID in the areas and the communities that we serve. So we have, starting on the 16th, was our first opportunity in the Del Valley area to stand up our RV unit and our testing team. And so just to give you just a quick update, generally the process is that as the community members come up to the tent that you see there in the picture, they drive up and we complete an assessment based on CDC guidelines. And if they need information about how to care for themselves and their family related to safety regarding COVID-19, that's where we start. We then ask them key questions to assess whether they would be available for testing, and that's based again on CDC guidelines. Following that, if we complete the test because they qualify based on symptoms and possible exposure, we proceed with collecting the testing sample. And then we are, to support also public health and the tracing approach, we collect a significant amount of information to ensure that we can follow up with them, and should there need to be further contact in supporting that effort as well. So with that, we opened again back in Del Valle, and on that first day, we were able to screen quite a few folks. There were 20 individuals there. We screened through 14 and then tested 10. And you can see as we went along in Colony Park, we had a great response to the first day of testing there, and then again returning back to Colony Park in Austin Colony. So I think what's really key here is the consistency that we'll have in going to all of these sites, so that we have an opportunity as more notice goes out to the community that we will be back, so that they can obtain their tests. The other sites that we're looking at to stand up, starting one at the end of this week, and hopefully as early as Monday on the other. So William Cannon, our goal, and again, this is all based on the fact that we have protective equipment that are staffing holes, and we have testing available to us. We will be offering a new approach that we will be trying at William Cannon and Pflugerville, and that is going to be a park test. So because there's limited space at those two locations, but we still want to be available, we will have where individuals will park into a parking space, and our teams will come directly to them. We will be having our first day at William Cannon this Friday, where we will be making that effort. We've had great partnership with the folks that we lease that space from, and we're working through with them on that. And then at Pflugerville, we're hoping to start that on Monday, and our plan is to be there on Monday and Friday. And how we will do that is we are also partnering and ensuring that we're letting our partners at that location know regarding the fact that we will be testing this park up approach to testing, and we're reaching out to our county partners at that location.
And for some perspective here, Board of Managers and folks on the phone and connecting virtually, we've conducted almost 2,000 tests across our system, and probably across Travis County right now, we're probably close to about 10,000 tests total. That number is fluctuating. The most recent number I looked at was 8,600 from the state, but that was based on last week. So I think the testing is probably close to 10,000. And you can see very quickly with 4 days in the Eastern Crescent, we actually tested 91 individuals. Those test results were trickling back, and so we're monitoring that to see what the results come back on. If you can advance to the next slide, please. Yvonne's got this one as well.
Sure. So, you know, and again, Jason will be giving you an update related to where we are with our PPE, but based on those numbers, we were able to reassess that we could safely return back to our Hornsby Bend Center, as well as our Del Valle site. And so last week we opened at our 2 locations. The other piece in continuing to grow that process, since we are at our Barbara Jordan location in Colony Park, we will have 2 programs going on at the same time. We will have testing occurring, and then medical services. So we'll begin that next week. Maze Crossing, our pediatric location, will be resuming, or actually resumed this week as well. So we're happy that we're back at our site. The next step, so our next area of consideration is community first village and our street medicine. And so the team is working to go ahead and have a good approach to reach out to our homeless patients in the community and ensuring that we have a safe methodology for our team and the patients so that we can deliver care for them.
Please advance to the next slide. And so, you know, one of the things with testing, I think that it's important for you as board of managers to know so far, and we have test results that are still pending, but the most recent up-to-date statistics is we've actually confirmed 229 individuals with coronavirus through our testing initiative. Separate and distinct from that 229, we've also had 7 staff members test positive, and those are direct staff members. We've also had 3 contractual individuals test positive. And that positive from a staff perspective has gone up of late, but we don't think any of it's directly tied to exposure. So for example, we had an individual who was working remote who ended up testing positive. And so just, you know, we all know it's within the community in that as well. So we're monitoring our staffing daily. For example, as of yesterday, we had 61 of our staff that were out for not the disease itself, but for childcare purposes or because they had symptoms that were there or were advised by a clinician to self-isolate. So testing still pending there. So we have 7 folks right now that are being worked up, just to give you some perspective. The other is as you take a look, as we noted last week, extremely important in order for us to protect our patients and to provide the quality care that we provide is personal protective equipment. And we're extremely thankful to Austin Public Health. They came through earlier today and we got some personal protective equipment to support the Eastern Crescent testing sites. So very pleased that came through. It makes our ability to provide these testing sites in harder to reach communities throughout Travis County and particularly Eastern Travis County areas that much easier. So very happy for that. So as you know, we're actively monitoring our PPE for personal protective equipment. And in so doing, we still have conservation methods that are occurring within. This just kind of defines it so you guys could read through this slide. If we can advance to the next one. We want to go ahead and apprise you just where we are. So you have line of sight. And so these numbers are going to look very good. And so we have about 30 days or so on a barrier mask. Think of that. That's actually this one. Yvonne and I are separated enough, but barrier mask is just a simple surgical mask, right? And then we have the N95 respirators that are the masks that we need to have when there's a known or possible exposure. We're at 48 days. And then face shields, right? Which cover our staff's face when they're seeing patients. So those all seem very high. And as I mentioned last week, the reason why we're able to reopen sites is because through our conservation efforts, additional supplies being secured, and then really notably is the significant decrease in our on-site patient demand. We're only serving about 15 to 17% of patients on site now. That has a direct impact. So if we say that we're at 20% of normal right now, what you have to realize, and what's highlighted in yellow at the bottom of this slide, is that if we got back to 40%, so things open up, right, within the community in the coming weeks, whatever that looks like, we end up seeing more as folks get back to what would be perceived as normal life. What will end up happening is we'll see increased demand within our clinics. If that goes to 40% demand, then each one of these days get halved. If we get to 60%, then we're down to 15 days on N95s. If we got to 85, then we're down to 7.5, and we start really panicking on our side because an uptick or surge would go ahead and require that we use more and more of our personal protective equipment. And so our procurement staff has set a goal of trying to get to 30 days on everything, but that would be based on normal operations, and we're nowhere near that with our supplier right now. So just want to give you a perspective. This is a moving target day in, day out. It's dependent on the supply chain. We want to be transparent not only with you as the board of managers, our own board here at Community Care, but the community at large. So we're providing updates. If you can advance to the next slide. And the other, as we mentioned, we just continue to do a ton as it relates to telehealth. So that's really our new norm. About 1,300 visits total a day is occurring across our system. With that stated, about 70% or so is occurring via telehealth. And really, folks don't need a smartphone. They just need to have access to a phone. And so I know that Central Health, through the MAP Basic program, is going to survey patients for their experience. But what we've heard anecdotal from both our staff and from patients has been very positive. And Madam Chairperson, Madam Chair, that concludes our report for this evening from Community Care.
Thank you so much. Are there any other presenters on this item?
Yes, Jeff, I have a couple slides to go through here.
That's what I thought. Please continue.
Yeah, thank you. I'll try to be brief.
No worries.
I want to talk a little bit about just real high level federal funding, what's out there. I want to also talk about fiscal year 20, just give an update on not only Central Health, but our other entities across the enterprise. And then talk about a little bit at a high level, some fiscal year 21 challenges or risk as they exist. So as you see on this slide shows a whole slew of funding from the federal side to different organizations. You may have read over the last few days that the city of Austin and Travis County had received some infusions of cash, and that was related to the coronavirus relief fund. You see the amounts listed there: 170, almost 171 million for the city, and then 54 million for the county. There's a number of funding streams related to the hospitals. The initial funding was related to what's called the CARES Act. And that's really the first two bullet points there. It was basically about $100 billion that was designated to hospitals. There was an immediate infusion of $30 billion to hospitals based on Medicare fee-for-service allocations. And so we did just an estimate based on running that formula. And we think that in Travis County, of that initial infusion, Travis County hospitals received almost $33 million. Related to the CARES Act, there's an additional $70 billion that has not been determined how it would be allocated, but there's been discussion about allocations related to rural hospitals or some focus on Medicaid or uninsured. So that remains to be seen. It's still a pretty large amount of funding that's still out there to be allocated to hospitals. Also, either related to the CARES Act or other acts, there have been some other additional funding enhancements, enhancing or increasing the FMAP, or what is the ratio to match for federal funds, has increased by 6.2 percentage points. So what that really means is there's a requirement for less federal funds to draw down, or less local funds to draw down more federal funds on a pro rata basis. You always hear us talk about dish cuts that may be pending. Well, there was action to eliminate $4 billion of upcoming cuts this year, and then $4 billion of cuts that were scheduled to occur next year. That has been eliminated. And then there's been some enhanced funding around Medicare, both increasing Medicare rates for COVID patients, and then also paying Medicare rates for uninsured patients in hospitals. And then lastly, but certainly not least, there was some recent legislation that was passed by the Senate that allocates $75 billion to hospitals out of a very large chunk of COVID-19 funding. I believe it goes to the House tomorrow. And I think, again, the premise would be approve the legislation and get it out the door, try to accelerate payments. In addition to that, there's been an acceleration of our typical supplemental funds related to uncompensated care and disproportionate share, which simply means taking into account even the increase in FMAP, to get cash to the hospitals, they're accelerating or moving up the payment dates for uncompensated care and disproportionate funds. So on the community health centers, you may have read a couple of days ago, there was some HRSA supplemental funding. It was I believe $100 million aggregate funding. And in the funding, in that supplemental funding, community care received about $3.7 million. And then a couple of other FQHCs in our area, Lone Star and People's Community Clinic, also received substantial funding through that allocation. And then there was a small public health and emergency fund funding that community care received also of about $240,000. Last on this chart is Central Health. We have put an application in to request FEMA public assistance. The way this works is you apply for public assistance, you gather up eligible expenses as it relates to the disaster declaration, and you're typically reimbursed for 75% of those eligible expenses. So we have just begun that and have some work to do on that process. Next slide, please. So just looking at fiscal year 20 and looking at not only Central Health, but our other entities in the enterprise. Central Health as an entity on a revenue perspective, our main revenue source are property taxes, and property taxes make up about 92% of our revenues for fiscal year 20. And as you know, property taxes generally are due or paid in December and January. They're actually due at the end of January. And so we are at a 99% collection rate for fiscal year 20, which means we're at our high peak for cash for this year. So cash-wise, we're in a good position. Also, our reserve levels, as we budgeted for fiscal year 20, budgetarily we have about a little over $62 million in reserves. Those reserves are comprised of our emergency reserve of about $38.7 million, and then our contingency reserve of about $23.4 million, plus an additional $2 million that we have for primary care expansion we budgeted related to fiscal year 20 also. Looking at community care briefly, and Jason did a great job of outlining some of their challenges. My chart below is almost the same chart. It's just slightly different. It's really the same data on the chart. At the bottom, the red line represents the budgeted encounters. So there's a little over 2,000 encounters per day that community care budgets. And you can see, and as Jason mentioned, they're at about 70% of the budgeted encounters, and that's primarily related to telehealth and the ability to provide telehealth encounters and also to get paid for those encounters. And that's mainly on the primary care side. The dental services present a different challenge. Dental services obviously can't be done via telehealth and are not reimbursed or eligible to be reimbursed through telehealth. So I think as it relates to dental services, it's a little uncertain of how those services may be resumed given all the challenges that exist currently. And then there's also a Deseret revenue shortfall just based on COVID testing and the focus on that and the patient services. Community care is basically paid for Deseret as they accomplish metrics. During the COVID pandemic, that Deseret has not been the focus, and there's some potential that community care for fiscal year 20 does not achieve all of the metrics that they had budgeted for in fiscal year 20. So that's something that we'll have to really look at down the road. Sendero was the first community plan that I was aware of that waived COVID-19 costs for its members, and I think that was a really appropriate action. I think our board was very supportive in taking that action so that members can get the care that they need related to this pandemic. To date, so far, of the over 13,000 members of Sendero, 5 have been treated for COVID. There have been some third-party assessments related to COVID and the potential impact. And based on those analysis, the third-party analysis, management felt like it was appropriate to conservatively reserve $2 million per quarter for COVID. And I'll come back to this in the next slide to kind of wrap up what some of the impact may be. And then on the community care collaborative side, we talked about Deseret revenue in community care, which again, they're paid on an ongoing basis. Once they accomplish a metric, they're paid for that on an ongoing basis. The community care collaborative is paid more on an annual basis through HHSC. And so the last performance period that we were in was at the end of December. So think of the performance period as a calendar year. So for fiscal year 20, we budgeted for that in the performance of that entire calendar year. And then we're in the process of reporting now. We have to submit reports of the metrics by the end of April. But COVID-19 did not impact any of those metric outcomes through December of last year. So for fiscal year 20, on the Deseret revenue side, we anticipate getting approximately $63 million, which was based on the outcomes of what we're reporting, which is substantially, I think, from an overall perspective, from a 100% evaluation, we're eligible for about $66 million. So that's a very high percentage of Deseret revenue for this year. Next slide, please. So as we look at fiscal year 21, property taxes again are our major revenue source. We've done a lot of financial forecasting based on certain rates over a 6 or 7 year period. We know that it's going to be challenging as we look at the economic situation. There also are some, due to the disaster declaration, other jurisdictions that may have ordinarily had tax caps imposed may be able to go back up to what was formerly called the rollback rate of 8%. So there's a lot of uncertainty on how all the taxing jurisdictions may be impacted. And certainly, as we look at modeling in our forecast, we'll take a lot of that into consideration. But our property tax forecasting that we've done may be somewhat in jeopardy based on some of the economics. We have been in the process of negotiation and mediating with Seton. I probably should have mentioned, I think I skipped over that in fiscal year 20, but we are still in the process of mediating with Seton. For fiscal year 20, we don't own any hospital risk currently for this year. And moving into fiscal year 21, there is some uncertainty on what if any, hospital risk participation we may have based on the hospital payment model that we've been working on them for some time. And then Central Health also owns enterprise risk, and hopefully that'll be apparent in looking through the other entities, what some of that risk is. But as you look at community care, of course, certainly a big risk would be, we've heard about the second wave, and, is that going to be even worse during the fall, during the influenza season? So that's certainly a big risk on the community care side that may impact our ability to in our capacity overall to deliver health care and look at financial circumstances related to that. And then also converse to that would be just the resumption of pre-COVID service levels. You heard Jason talk about physical PPE. So, that certainly could be a constraint. And as we move forward, there may be some other constraints related around certain service lines that we'll have to take into account. And then Desert revenue will be a continuing risk moving into fiscal year 21 for community care. And then they're also not that there's not enough going on, but they're also in the midst of a EHR, an EPIC, electronic health records implementation. And that's an implementation that, in addition to providing health, dealing with COVID-19 requires bandwidth. And certainly one of the things that you want to certainly take into account is if you have an EHR implementation that fails, that in itself can be very costly. So that's a big risk point as they progress in that implementation. On the Sendero side, simply they've had a third party look at COVID costs. They're doing a reservation of funds by quarter, but there's certainly, if those estimates are less than what actual costs are, that certainly is a risk given the hospital cost of COVID treatment. I've done a chart down at the bottom based on Sendero risk-based capital. I'm going to jump to that real briefly and then I'll come back up. So this is a chart that shows the level of Sendero risk-based capital over the 3-year period of 2018 through 2020. 2018 was 243%. Those are audited numbers. The 2019 audit is still ongoing, but management has given an estimate of risk-based capital based on where we're at now of approximately 729%, and then has forecast for fiscal year 2020 of a little over 700%. So it's pretty level for the next 2 years. When you take into account the $2 million per quarter reservation and look at the COVID range, and if those reservations actually get spent, that's where you end up on the dotted line there. The lower range of the COVID estimate would put risk-based capital at about 390%. So if you look at Sendero from an ongoing basis, it's a big decline in risk-based capital, but it's certainly at levels that have been higher than some previous years prior to both 2018 and prior to that. One of the risks that does come up related to the ACA, though, is cash flow. And if you remember, the way the risk adjustment works is you have a risk adjustment throughout the calendar year. So Sendero's on a fiscal year, their fiscal year is a calendar year, and you have the risk adjustment is calculated for that fiscal year or that calendar year, but you don't get paid until 8 months later. You typically get paid in August of the subsequent year. So there's definitely a risk that cash flow as it relates to the risk adjustment may be a risk that Central Health may have to address until Sendero gets paid for that risk adjustment. So that's something that we'll have to look at and model moving forward. And then lastly, the Community Care Collaborative on the desert revenue side, there's definitely a lot of risk as it relates to COVID for this current reporting period, which again is January of this year until December of 2020. There are two categories that have a lot of risk as it relates to the COVID-19 outbreak. Category C outcomes, the total value of Category C is about a little over $35 million. We feel like there's, of those outcome metrics, about 75% of those could be impacted by COVID-19. And so let me give you a couple of examples. One of our metric bundles are dental caries. Well, we're not doing a lot of dental work right now, so that certainly can impact the volume and the metrics of that metric bundle. We have some primary care type bundles, for example, blood pressure metrics that currently we have not received approval from HHSC to do any telehealth visits that would count toward metrics, nor can we do self-reporting, for example, of blood pressure of patients. So if we're not seeing a lot of patients face-to-face for blood pressure checks, even though we may be doing them via telehealth or some other medium, currently we're not being able to count those in the metric counts. So that's a couple of examples of how COVID-19 may impact our metrics. We've put in a number of questions and requests to HHSC, and I suspect after this reporting period is over, they may have a chance to address some of those. These are not unique problems to us. I think they're unique to a lot of performing providers in the desert program. And then last is some risk in what's called Category B, which is really more of a reporting category, but it is predicated on achieving certain patient volumes. And again, I mentioned telehealth is not eligible to be counted or to be included as an encounter. So we certainly run the risk if that doesn't turn for us and we don't have a more favorable ruling in that regard. A portion of the $6.2 million amount may be at risk as it relates to fiscal year 21 desert revenues. The 75% risk of the Category C, the 35 million, is about 26 million. So there's a pretty big amount of risk as it relates to that those bundles or those outcomes around that. So that was a lot. Thank you for allowing me to do this presentation, and that concludes my portion of it.
Do we have any additional speakers on this topic? I want to thank everyone. This is just an incredible enterprise-wide effort. All of our presenters, I know that you are presenting, but there are many employees who are working with you, and we want to thank all of you, whether you're doing communications or finance or patient reporting and tracking, and certainly with community care, the Herculean efforts that you have gone to have those testing sites in Eastern Travis County, and with reopening of those clinics. We applaud you, and we applaud everyone who has presented tonight. As I said, all the staff who are working with you. With that, members, I'll open up to questions. I see that Manager Musaitev has her hand up, and then I see Manager Valadez, and I think Manager Oliver after that.
Well, thank you, Chair. Thank you, everyone. I really appreciate your efforts. Thank you for all the information, wealth of information. I have a few questions. One is directed to a slide that Sarita posted about on 4/20, we had 1,008 cases. And are those our cases? And I'm just trying to figure out the numbers between what the city also has posted. So if there's some clarity on that numbers.
Sure. Those are all Travis County cases. All of those numbers are sourced from either APH or DSHS, and those dates are reflective of reporting dates, and not necessarily. And you'll see the numbers kind of vary depending on which source you're looking at. So DSHS will report those numbers that are being reported by APH on the day before. So even if you went onto the APH website today and looked at those numbers, you would see that it says that the report was updated as of 4/20, but those numbers changed since we looked at them yesterday. So there's a little, in terms of when the dates are, we're referencing the Travis County numbers, the DSHS numbers, I'm sorry.
So just to elaborate on that, managers, the dashboard that you will see if you go to the City of Austin, right, to the COVID-19 site there, or to Travis County, there is a dashboard, and that dashboard is updated by 6 p.m. daily. And those are Travis County numbers that you see on that dashboard, which are coming from, as was referred, multiple sources through the Emergency Operations Center and others. So it is fluid from day to day.
So would you be able to share with us how many of our patients have tested positive?
We don't have that information right now. We haven't gotten any of that detail, that patient level detail from APH yet.
Okay, and in terms of testing, I know that Jason mentioned that he so far tested about 2,000 individuals. Is that correct? And there's still shortages of testing. And what are the barriers of you getting these testings and securing additional testing?
Yeah, so happy to answer that, Maram. And so, yeah, approximately 2,000 tests since we initiated testing on March 11th. Actually, March 11th was the first day that we performed our first test. The supply of testing has improved over the course of the intervening weeks. We're now averaging across our system close to about 80 tests a day to 100 tests a day. And so we're able to secure the tests that we need so far. If there's need to test more folks, we still have concerns in terms of test medium and other materials that are needed but we're in a pretty good place. The biggest issue right now is we're back to almost a 5-day lag time in results coming back, which means that there's just a lot of demands on the reference labs that we're working on processing or testing materials, or the tests themselves, I should say.
And are you not, all your testing are not, you're not performing any antigen testing, is that correct? Or
we are not. We have received through partners, through the Texas Association of Community Health Centers, we did receive 500 Helogen antibody tests, but we have concerns that are shared with APH and others about the sensitivity and specificity of those tests, given that they can provide false positives relative to other strains of either coronavirus or similar viruses that have similar proteins or antigens. And so the antibodies come back, or the test comes back with a false positive. And depending on the test, the one that we received is sourced out of China. It has a false positive level right now of around 30% based on documentation. With that stated, these tests, the antibody tests, with the exception of one, have not been authorized by the FDA under emergency use, but rather are being used for research purposes only. And so when and if we implement antibody tests, it's really a validation study, a research study that would go ahead and confirm whether or not it's a viable test to be used. And right now, none of these antibody tests are supposed to be used for diagnostic purposes. They're not to render a diagnosis. They should be used in conjunction with the reverse transcriptase preliminary chain reaction test because of the validation issues. Now that may change in the course of weeks as tests become more validated, but right now we are not using them given the issues around false positives.
Okay, and another question related to contact tracing, and thank you to APH for stepping up, providing us PPE supplies for the Eastern Crescent, but also them stepping in to do the contact tracing. Now, I don't know, maybe late offline we can discuss the process and how it's being conducted. And also my other concern is the time lag. You're saying 5 days in the contact tracing. So that's a concern of mine. And my last question will be in moving forward with opening this potential sites of William Cannon will only be 1 day on Friday, and Pflugerville Health Center, you said Monday and Friday. Is that correct?
So William Cannon will be Monday, Wednesday, and Friday, and Pflugerville will be Monday and Friday. And then back to the contact tracing, we executed an agreement with Austin Public Health Department last week, where our staff and then some of the staff with an agreement with us from Central Health. So this is a joint enterprise initiative that we've worked with Austin Public Health. We'll actually be doing direct contact tracing not only on our patients, but also on community members if needed. And we're also partnered with UT Del Med, and we'll be using their Sentinel system for the contact tracing, which is basically a technology solution, software solution that emerged out of the Washington area. Now that's going to be used and is being used by UT Del Med. And so we're doing that. We share your concern. We want our test results back within 24 to 48 hours. It's just the pressures relative to, of course, anyone that we do test, we indicate to them that they should be self-isolating, and then we'll stand ready to do contact tracing when appropriate.
Thank you. Yes, unfortunately, we can see that there's a supply and demand issue with getting those test results back. We would love them in the 24 hours, but it looks like right now the demand for processing those tests is outpacing the supply and the ability to process them as quickly as we would like. I think Manager Bauer.
Just one second. I just received just a quick question. In terms of the clinics that for Pflugerville, would it be a drive up or a referral to get a test? And that's my final question.
No, great question. So it would be, it's neither. It's actually, we're going to ask the patients who are coming only or community members for testing is they pull up in their vehicles, and then our testing staff will come to them. But they don't have to have a referral. It'll be open to the community, just like other sites. The difference there is we just logistically can't manage drive-through at our Pflugerville or William Cannon site. And we're still securing permission to be able to do it at both. But William Cannon will stand up later this week, and we're hopeful Pflugerville will come online Monday of next week. And then both of those clinics are operating as per normal. And so this will be outside the clinic itself.
And Jason, just to reiterate, you don't have to have referrals for any of our testing sites. When you come, you will be pre-screened, and if you have the symptoms according to CDC that dictates that you need a test, then you will receive them without any kind of referral. Is that correct?
You are spot on, Madam Chair. Yes.
Okay, and that we do have those two clinics where, because of the space situation, people will remain in their parked cars and clinicians will come out to them to do the test, correct?
That's correct. Our intention will be as our testing staff will come to them, yes. And they'll be outside the buildings, readily able to identify who's coming in for testing, yes.
Thank you so much. All right, I think Manager Valadez, you had a question, then I believe Manager Oliver had one. Manager Valadez? You need to unmute. You need to unmute.
Really short. Can you hear me? Can you, okay.
Yes, I can hear you. Thank you.
Thank you, Chairperson Sherry. This is for Ted on outreach and whoever's making the phone calls. First of all, I want to thank you all for doing this, but as Sarita pointed out, we still have a major problem in the Latino population. I don't know with respect to the demographic, whether she can tell whether or not that's English speaking or bilingual or monolingual Spanish. Is there a way to know that, Sarita?
No, that information isn't being reported right now by EPH that I've been able to find. I did look after your last comment. I haven't found it.
Okay, well, let me tell you, I'm getting a lot of calls and a lot of concerns from people in the community and advocates who advocate for like the Spanish-speaking population, because many of them are still working. They're working on an hourly rate. They get no benefits. They're construction workers. They're digging ditches for the pipes. They're doing all kinds of stuff. And so I guess not to you, but to Ted, with respect to reaching out to this population, is there any way that we can talk to maybe Texas Light or to for the city of Austin, Austin Energy, or the water department, or out in the county, something else to be able to have them include some kind of a notice that this is a number that they can call if they're not insured and they need access to services? And because I noticed that he also talked in terms of there's an opt-in code, and in addition to that, I wanted to know whether we can add that opt-in code, like a little line for our MAP Basic and CHAP applications, so that we don't have to, for future purposes, go back and start calling and calling and calling again. Is there a way we can add a line on the application to help diminish that?
Cynthia, this is Ted Burton. I'll let Kit perhaps answer the question about the application, because I'm not sure about that, but we are actually in conversations with the city of Austin. We're also on, I think, at least I'm on 3 different weekly conference calls with regional PIOs and Austin Public Health. So I think that's a good idea. We are sharing the texting information. We were just trying to get that solidified today. We are also continuing to do radio, paid radio advertising, which also comes with it complimentary interviews. So Yvonne Davila and Monica Saavedra have been doing Spanish language radio. And now that we have that texting component shored up, we'll be promoting that far and wide.
Okay, and would it be possible for us to maybe entertain the possibility of bringing in experts who are proved able to get deep into that hard to reach population, especially in the minority communities, the color communities, and the non-English speaking language communities? I'm just curious as to whether that's a possibility for a short period of time.
I mean, so you're actually like bringing contractors, consultants to assist. I want to make sure I understand the question.
Yes. Yeah.
I mean, we would be open to any support from experts outside our own experts on our team and our community. We are also using our community health workers, and they're the ones who are making the calls to the MAP members. All the calls are made by bilingual community health workers. And that way the person that answers the phone can decide which language they prefer to use.
Well, the reason I brought up this issue was because there's so many people in the contracting and construction business that are hourly wage earners, and they may not answer the phones, and you need somebody to call them at alternative times, not necessarily during the day, at home after 7 or 8 when they get there. So that's the only reason I brought that up. So but I want to tell you, thank you for all the work that y'all are doing with respect to that.
Thank you. Thank you for the input.
And one more thing, just one more, is I noticed in the demographic, no, maybe it was I don't know which slide it was, Sarita. You have 2 Colony Park mentions for testing. There was Colony. There was Austin Colony, Hornsby Bend, or what, Del Valley, and then Austin Colony, Colony Park, and then Colony Park. There were 4 sites. I was just curious about that.
I'm sorry, Manager Valadez, I don't think that was my slide if it was to
Whoever slide it was.
testing.
I think it was Jason's slide.
On the demographic, I thought it was before Jason.
We may need to get back to you on that.
That's
Why don't
fine,
we get
that's
back
fine.
to Manager Valdez on that so that we can keep moving?
Yeah,
Manager Alden, do you still have a question?
I have just a couple. I think they're pretty quick. Jason, do you know how many folks have wanted tests but haven't been able to get tests because they don't meet CDC guidelines? And will you quickly address, just for the folks in the audience, like what are the CDC guidelines to get tested?
Absolutely. So folks who are coming to our site, we've seen probably closer to almost 3,000 unique individuals, and these are estimates right now. We follow up with hard numbers, but I'll use our Hancock Testing Center as the example. So there's roughly 2,000 folks who have shown up, of which around 1,500 or so have been screened medically, and around 1,200, so 300 of the individuals who were screened medically were disqualified for actual tests. That the difference between the 2,000 to 1,500 is really just individuals who have questions, concerns. We answer that, it's more general information. Then we medically screen folks, and the criteria that we're following relative to CDC right now is folks who are symptomatic. We've got enough tests right now where we literally had a stoplight report that said, okay, we're only doing high risk, medium risk, low risk individuals who are symptomatic. The high risk initially were folks who were over the age of 60 or had comorbid conditions. Right now, we're at the point when anyone who's presenting with symptoms is getting a test, and that could be shortness of breath, cough, dry cough, fever, all of those things that are consistent not only with coronavirus, but also with influenza-like symptoms. Anything to add to that, Yvonne?
No, I think that's it. And based on our clinical leadership with Dr. Shasha and Dr. Yagoda, we're constantly monitoring based on the number of tests that are available, where we fall on that green, whether we're green, yellow, or red. And so we have been for well over almost 2 weeks now where we've been able to maintain that green level. So we're testing more folks on a daily basis because we're able to sustain that level of testing available to us.
Great, thank you. And because I think there's some confusion sometimes with people have to have been exposed to somebody who was a positively confirmed case. Is that part of what y'all screen for?
We do as well, but that's not a predictor necessarily of whether or not someone's going to get a test or not. Actually, based on CDC guidance, if someone has a known exposure, they're actually advised to self-isolate for 14 days if they're asymptomatic. If they're symptomatic, they just fall into that group of folks that we're going to test. But if they're asymptomatic, they're advised to self-isolate and follow up. And we do follow up with folks who've called our hotline as well relative to a potential exposure.
Yeah. Well, I was thinking more for the folks who don't have a known exposure, but definitely have symptoms, because I think there's a lot of confusion on whether those folks can actually get tested under CDC guidelines because there's just a limited amount of tests.
Right now, we're very pleased to report that if someone comes to one of our testing sites and they're symptomatic, we've had sufficient tests to be able to provide a test to them the last 2 weeks. Yep.
Good. And I just want to reiterate what the other managers who've gone before me, like thanking everybody who's doing this, and whether it's healthcare providers or y'all working from your offices. I know this is hard, and thank y'all. I know we all feel a tremendous amount of gratitude for y'all. I think my last question is for Jeff. And I know we don't have probably a clear financial picture, and it is good that we are getting some federal assistance to, especially community care. Do you think that some of that federal assistance will offset some of perhaps the budget misses from the regular volume declines?
Well, sure. I think we hope so. I mean, the question is going to be to what extent are those budget declines, how long do they last?
Yeah.
It's just right now, it's hard to say. I think there are other potential funding sources out there that may help alleviate it also, but we just don't know at this point. We just need more time to model this a little bit further.
Understood. I can't imagine how difficult that is right now. Those are my questions. Thank you all.
Thank you.
Thank you. Manager Jones, did you have a question?
Yes, I have a few questions, if I may.
Please.
I'll make them rather quickly as best I can. First of all, I'd like to join with my colleagues in thanking you all for a fantastic job you're doing out there. And the report today was excellent. I was very impressed with the comprehensive nature of it. I personally had the opportunity to actually be screened at one of your sites, and it was very professionally done and very efficient. And I want you to know that as a board member, but also as one who's in the high risk category, that I was very impressed with the work that was provided. I'm a citizen just like everyone else. I want to start off with those comments. A couple of things, though, I did want to ask. I think most of the questions that I've wanted to ask have already been asked, so I'll just a couple of them. And they relate to our sites, and some of you're probably aware that our sites at Hornsby Bend. I've had several calls and concerns about the logistics of getting in and out of that site there in Austin's Colony. I understand there are some issues out there in terms of wanting the site or whatever, but have we been able to make sure that that site is adequate in terms of being able to get in and out access to the location?
Yeah, Manager Jones, very appropriate question. Yes, we actually did a pre-assessment of the HOA facility and the way that the street is set up, and actually has an easement next to the park, and that's what we're using. And so the first day we had out there, which was on Tuesday, went very well. And it is. We've heard similar concerns, not so much about the traffic in and out, but just the fact that there are folks who are potentially exposed to, or not exposed, but are coming to get tested for coronavirus into the community. The vast majority of folks that we are screening at that site are drawn from that community directly.
But as we ramp up, and our expectation is that we ramp up, the question is that going to still be able to accommodate that? I used to live in that community. I'm somewhat familiar with the roadways in and the roadways out. And it's not just for that community, as I understand it, it's for the entire Hornsby Bend area. So as we add other neighborhoods and outreach, which I hope we're doing, then that's going to be problematic. So my question is it conceivable that as you look for ramping up that location, that we look at another location, maybe a school in that area, that would be more accommodating to a large number of traffic?
Yeah, a school would have been ideal, and I'll defer to Central Health because they worked with Del Valley ISD. My understanding is Del Valley ISD declined to have us actually have testing on their grounds. That's what I was informed.
Did we talk to the superintendent?
I was not directly, Shannon, I was not directly involved in those conversations. I'm not sure who was on Central Health side.
Mr. Giesland, can you add to that? Or
This is Ted Burton, and Yvonne Davila can join in as well, but we spoke with staff there, not the superintendent. So it was their communications director, and I believe it was the director of nursing.
That's correct, Ted.
And they've indicated they're not willing to allow us to do screening on their grounds, even though they're closed presently.
At that time, go ahead, Yvonne.
They are distributing food to families, and their concern is the safety of families coming to receive food.
Are they distributing school food at the sites, at the Gilbert Elementary site and or the Del Valley, I think it's middle school site?
The ask was for Hornsby Dunlap Elementary and for Del Valley High School, and that was the answer that I received from them.
So we haven't asked about Gilbert.
We have not.
I just raised this question because one of the challenges with this part of the county is access in and out. there's it's two ways in, one way in, one way out in terms of 2 lanes. And getting into that subdivision is problematic. And I would imagine as you go forth, you're going to continue to see issues with regards to access to that location. So I raise that to you as a concern. I'll leave it at that. The next thing, no, I have a couple more questions right quick.
Oh, sure, of course, please proceed.
This next question relates to, okay, we've opened the facilities we closed. Is that right? The back to services at the Hornsby Bend, is that located, is that correct?
That's correct. Yes.
Okay, one of the concerns I've also heard is that as we ramp up services both in that new location and as the old location, the accessibility again to that part of the county. I have spoken with the commissioner, and I'll be honest, I don't think he's happy at all with the way that process has come forth. And many people in the community have shared that to him, but also to me as well. And so I think that as we go forth with these changes, we need to look at if we're going to make changes, and I understand being under the gun, I've been through this process myself, that if we're going to start making changes, we give a little more time at least to communicate to the elected officials and board members that we're going to either close something and open something. And if we're going to not utilize facilities such as schools and others, which I'm hearing you saying, and use what we have available, that we do the best we can to try and make sure that those things are readily accessible, or egress and exits out of those areas. Because there's some real challenges with the location you have. I know it personally. As I said, I'm familiar with the area. And so that's just a word of caution as you go through the process of ramping up and changing things, not only in this area, but other areas within the county as well.
Yeah, Manager Jones, really appreciate that guidance. Thank you.
I think for now, those were the only questions I really need to ask right now. Just a word of caution with regards to those things, because this is a very serious disease, as you know, and we're going to be significantly impacted over the next several weeks and months. Thanks very much.
Yes, thank you, Manager Jones. Yes, indeed, and we certainly share the concerns about proper notification. Very, very important. All right, members, is there anyone else that has a comment? If not, we will move on to the next agenda item.
There was a question posed in our group chat from Manager Musaitis about how many patients didn't get tested, which has to be answered verbally.
The question is how many patients did not get tested, who asked for a test, or what's the question?
Just follow up. I believe Jason mentioned there were 2,000 people and 1,500 were, I just wanted to, the numbers that I missed those numbers. Was it 400 and 500 or the people were not tested?
Yeah, my computer died on me, so these are ballpark right now, but, and this is our Hancock testing site only. And so I'm drawing from that. We've done testing within the clinics and elsewhere, but in the clinics, there's a complete medical evaluation. So anyone who had symptoms and warranted a test, they would have been tested in the clinic. We haven't had any issues with that I'm aware of. Relative to Hancock, we've seen roughly through yesterday, approximately 2,000 unique individuals have presented to the drive-through, of which about 1,500 progressed from just general information. So we went from 2,000 down to 1,500 who were medically evaluated. Of those the individuals that were medically evaluated, between 1,200 to 1,300 were actually tested based on their symptoms. Several weeks ago, like 4 weeks ago, 3 weeks ago, when we were in a red gradient relative to what we discussed earlier in terms of not having a ton of tests available to us, we were only testing folks who had symptoms that were 60 plus years of age or had comorbid known disease processes. As more ample tests have become available, we've been able to test more folks. So I can say with confidence, the last 2 weeks, anyone who presented at our Hancock drive-through that was symptomatic would have received a test based on that evaluation and work up by both our nurse triage as well as an attending clinician there that are following very strict guidance from our chief medical officer as well as our associate medical officer.
Thank you.
Thank you for that important information. All right, members, I think we're ready to move on to agenda item number 3. Okay. Agenda item number 3, discuss and take appropriate action on a request by Sendero Health Plans, Inc. to modify amended and restated debenture number 1. Jeff Canoda will be presenting.
Thank you, Board Chair Jeff Canoda. This item, we are requesting, staff's requesting action on this item. I did include a memo in the packet related to it. So this item entails an amendment, a proposed amendment to change the trigger of a Sendero surplus debenture that was initially approved in December of 2015. Staff came back to the board in December of 2019 requesting an amendment to change the trigger or the trigger event that requires the debenture to be paid back over time, and paid back over time is a 30-year period. It's a very long time, but the key is it triggers that event or those payments to begin. And so the term of that trigger that was approved in December of 2019 was the greater of RBC in amount of $1.5 million or a 3-year rolling average of risk-based capital of 500%. The amendment that we're requesting is still the same amount. It's the greater of $1.5 million or 3 consecutive years of risk-based capital levels of 500%. And the reason that we're asking for this change is Sendero needs to be financially capable to repay the debenture at the time this is triggered. And if, typically if you use a rolling average, there could be a scenario, and I'll use a couple numbers as an example. For a 3-year rolling average, if there's 700% of RBC in year 1, 600% in year 2, and then 200% in year 3, that's an average of 500%. The problem with that rolling average is that's the low point of risk-based capital, and that's the least appropriate time that Sendero is capable of beginning to repay the debenture and have interest accrue on that debenture, on the surplus debenture. So we're simply requesting an amendment to the surplus debenture to amend the term or the floor that triggers the repayment from a 3-year rolling average to a term of 3 consecutive years of 500%.
Okay, so Jeff, really this is just a more mathematically conservative manner of doing this, right?
Yeah, okay. Absolutely correct. It's conservative, okay. And again, it would be a more appropriate level for Sendero to begin repayment of that surplus debenture.
Thank you, Manager Bell.
Chair, I'd like to make a motion. I move that the board amend the motion previously adopted related to the First Amendment of the Sendero surplus debenture, which was made by the Central Health Board of Managers on December 18th, 2019, by revising the definition of surplus floor so that repayment of the debenture is triggered when risk-based capital, RBC, is at 500% of RBC for 3 consecutive years.
I think I saw Manager Valadez's hand first. So there's a motion by Manager Bell and a second by Manager Valadez. Any further discussion? Hearing none, all in favor say aye.
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 Opposed, same sign. Any abstaining, same sign. Seeing none? All right, the motion passes. Thank you, members.
Thank you.
All right, we will now move to item number 5 on our agenda. Discuss and take appropriate action on a contract with Perkins Co. LLP for legal services in an amount not to exceed $375,000. Monica Crowley will be presenting.
Thank you, Manager Greenberg. This is Monica Crowley. This staff is requesting action on this item, and the item is to request approval from the board for the president and CEO to execute a contract with Zubin Kambata's new law firm, Perkins Co. You have met Zubin Kambata before when he's presented with David Hilgers from Hush Blackwell regarding the Central Health Ascension Texas mediation. Zubin is also our counsel for matters regarding the LPPF and other state Health and Human Services Commission and Federal Health and Human Services Office of the Inspector General matters. Zubin is an expert on the 1115 waiver and supplemental Medicaid funding programs and has been part of the team at Hush Blackwell representing Central Health for the past 3 years. In March, immediately before the current pandemic crisis, it became apparent to all of us, Zubin left Hush Blackwell to become the main health law counsel for Perkins Co.'s new Austin office. And this item is merely about engaging Perkins Co. to allow Zubin to continue his representation of Central Health. This item has no budgetary impact. He will be would contract with him for the same rate that he was charging when he was at Hush Blackwell. And we're not asking to contract for any additional services over the services that have already been budgeted for these legal services. The not to exceed amount for this request is for an annual amount not to exceed $375,000.
Thank you. Members, any questions? Manager Musaitov?
I was just going to entertain a motion.
Okay.
I had a question. Is there any impact with our relationship with Herschel, with the other firm? I'm sorry.
Hush Blackwell.
Hush Blackwell. I get it confused. There's
Yeah,
no impact.
no, Manager Jones. We'll continue to engage David Hilgers through Hush Blackwell. The spend will be split between the two law firms now.
Thank you.
Okay. All right, thank you.
Manager Musaitov?
Yes. I move that the board deem employment of additional private legal counsel necessary for matters related to the Medicaid Disproportionate Share Hospital Program and 1115 Medicaid waiver, the Travis County Local Provider Participation Fund negotiation of agreement with Ascension, Texas, and other matters as assigned by Central Health, and authorize the president and CEO to execute a contract with Perkins Co. LLP for legal services in an amount not to exceed $375,000.
Okay, there's a motion by Manager Musaitov. I see a second by Manager Valadez. Okay. Any further discussion? Seeing none, all in favor say aye. Aye.
Aye.
Opposed, same sign. Any abstaining? Okay. Thank you, managers. The motion passes. We will now move to item number 6 on our agenda. Receive an update on the annual performance evaluation of the Central Health President and CEO. Susan Willers will be presenting.
Good evening, Manager Greenberg and managers. Nice to see all of you. I'm going to share my screen very quickly. Can you all see my screen?
Yes, I can see it. Thank you.
Okay. So in your packet, I sent you a memo, and the memo really outlines the process that we're going to use this year for the CEO's evaluation. The process is very similar to the previous years. The tool that you will use this year was approved last year in June of 2019. And I would just like to very quickly share with you the process that we're going to use. The tool does include 3 dimensions, and they're the same dimensions that we've used in the previous years, and that is the strategic leadership, that comes out of the strategic work plan, the board relationship, and the professional development. And so we're going to start the process next week on the 30th. Mr. Gieslin will provide a self-evaluation and a written report on the feedback that he received from you last year. On May the 1st, I will send you the evaluation tool. It's in your packet for review, but you won't get it until May the 1st, and I will go ahead and include the self-evaluation and written report from Mr. Gieslin. And then on May 20, you all are to send me your individual evaluations so that I can compile them and put them together into one final evaluation. On the 25th, I will send the evaluation to all of you to review. On the 27th, we'll meet with the executive committee virtually to review not only the completed evaluation, but also the employment contract. On the 28th, the board, all of you will meet with the president and CEO to discuss the evaluation and contract terms. And then I'll come back in June to talk about the 2020-2021 evaluation tool. And that completes the process. When you get the evaluation tool on May the 1st, I'm also going to send you a copy of the contract, the fully executed contract, so that you can review it. I will entertain questions, and I'll turn it over to you, Manager Greenberg.
Thank you very much. Appreciate that. Members, this is the same evaluation tool that we used last year, and I believe that there is no need for change. We had made revisions previously. I think it's good to have some continuity. So we have a schedule here. I do think it's important that we proceed with the annual evaluation on the regular schedule. Any questions, members, on this item? If not, yes, Mrs. Manager Jones.
Yes, so in terms of the review, I participated for my first time last year. So it was a learning experience. So this year I'm a little more aware of it. Are there other documents that are part of it that is provided, or are there documents that we need to substantiate our evaluation that we will request? What process does that go through?
So the only documents that I'm not sure I quite understand your question, but you will receive a self-evaluation. I think last year what happened was the self-evaluation from Mike came after the fact, after you receive the tool. This year you're going to get it when I send the tool. So you'll have that self-evaluation when you start the evaluation process.
Okay, yes, because as I said last time, it was really my first time, and it was a learning experience. So we'll have that first. If there's other information we'd like to have as part of our evaluation before we submit it back to you, to whom should we direct those questions? To you or whom?
To me. Yes, to me.
Okay. All right then. Thank you.
All right. Thank you very much. Anything else, members? If not, we will move on to the next agenda item. The next agenda item is agenda item number
Manager Greenberg, I believe Manager Valadez has a question.
Oh, thank you. Manager Valadez, yes. You need to unmute. Thank you.
I said dadgummit. Okay. I want to thank Manager Jones for bringing that question up, because that was an issue that I had last year, and maybe the year before, but I know it was specifically last year with respect to we having to rate him based on his relationships and interactions with staff. And the issue was going to be, how are we going to know what that component of the evaluation would be? And so, Susan, I think I remember speaking to you about this, and that's still going to be a question. I haven't seen, I'm assuming it's going to be similar. So that is going to be another issue if that question is still on the evaluation tool.
I don't have the, yes, I'm not sure if that is a question or if that was more on the tool itself.
It was a component. That was, you had the various issues, and that was one of them.
Yeah. Or maybe it was an opportunity that you all listed for him. So I will go through the tool and review that with Mr.
Please do, because I remember specifically sitting next to Manager Jones and asking him, how are we supposed to be able to answer this if we don't have access to that information? That's internal. He is our face. He's the person that we communicate with as the CEO, not the rest of staff. So how are we going to have access to that information? I didn't understand.
And Manager Greenberg, I think that if this is a question on this tool, maybe for the 2021 tool, we can work on that wording for that section that Manager Valadez is pointing out.
All right, thank you, I appreciate it. So if you'll get the information back, and we could do that for a future one, and I'm sure there would be other ways to address things with this, the process for this year. Thank you.
You're welcome.
Anyone else? Okay, not seeing anyone, any other hands, but alert me if I have missed you, please. I'm doing the visual scan here. We will move on then to agenda item number 4, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition or lease, including delegating authority to execute contracts for such property to the president and CEO. Holly, do we need to move into closed session at this time?
Yes, ma'am, we do.
That's what I thought. So I am moving that we are moving into closed session with agenda item number 4 under section 551.072 of the Texas Government Code, deliberation regarding real property. So members, everyone will need to leave this. Am I correct, Holly? Everyone must leave.
Correct.
Clock out of it, leave it. And we have another venue to go to for our closed session. Then you will clock out of that when we finish our closed session, and you will have to clock back into this venue. Is that correct, Holly?
Yes, ma'am.
All right. Thank you, members. I will see you in the next venue. So I'm announcing that the board is coming back into open session on agenda item number 4, discuss and take appropriate action on Central Health owned or occupied real property and potential property for acquisition or lease, including delegating authority to execute contracts for such property to the president and CEO. Members?
Chair?
Yes, Manager Valadez?
I'd like to go ahead and make a motion.
Okay.
That the Board of Managers delegate to the President and CEO the authority to negotiate and execute contracts to purchase land for clinical expansion projects in eastern Travis County, including but not limited to Colony Park and southeast Travis County, on the following conditions. The purchase price must be less than or equal to fair market value. The purchases must be reported to the next Budget and Finance or Board of Managers meeting, whichever is sooner to occur. And the purchases must be approved by the Travis County Commissioners Court in accordance with the Texas Health and Safety Code, section 281.050. I further move that the purchases be effectuated as soon as possible in order to evidence the board's commitment to the residents of those historically marginalized areas.
Okay, I have a motion. Is there a second?
I'll second.
Okay, Manager Oliver seconds the motion. Is there discussion, members? Any
Call for
discussion?
question.
Okay, no, I don't see. Manager Valdez has called for the question. So all those in favor signify by saying aye. Aye.
Aye.
Opposed, same sign. Any abstaining? Thank you, members. The motion passes. Members, I need to recall agenda item number 1, discuss and take appropriate action on proposed amended mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2020 in connection with the local healthcare provider participation program in Travis County. Managers, is there a motion? Manager Musaitif?
Yes, I move that the board postpone consideration of agenda item 1 until April 29, 2020.
Thank you. Is there a second? Manager Musaitif made the motion. Manager Valadez seconded the motion. Any discussion? Hearing none. All in favor say aye.
Aye.
All opposed, same sign. Any abstaining? Thank you, members. The motion passes. Okay. We shall now take up, members, drum roll, please.
Item number 7.
Agenda item number 7, confirm the next board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting will be a special call board meeting on Wednesday, April 29, 2020 at 5:30 p.m. remotely by toll-free video conference and telephone. At this time, I'm ready to accept a motion for adjournment. Manager Valdez makes a motion.
I'll second.
Manager Musaitif seconds the motion. All in favor say aye.
Aye.
Opposed, same sign. Any abstaining? Members, we are adjourned. Thank you
Y'all
very much.
stay
Thank
safe.
you, everyone.
Bye.
Bye-bye. Thank you.